we'll start with jaundice. Jaundice is very important. Jaundice is one sign, or you can say symptom also. Sometimes patient presents with it, and it turns a doctor into a detective, because not all jaundice is full of concern, and sometimes a patient of jaundice could be a surgical emergency as well. So there is a spectrum of diseases which can present with jaundice. Is my screen visible to you all?
No, not is that, sir.
Say again.
Yes, 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 sir. Visible,
Okay.
visible, sir.
So jaundice
It is
in in a common term is known as hyperbilirubinemia in a technical term. It is defined as yellow discoloration of the body tissue resulting from accumulation of excess bilirubin. Now, it only indicates that the production and excretion, they are out of balance. Either the production is high or the excretion is low. So the balance that exists between the synthesis and excretion is distorted. Normal levels are less than 1 milligrams, and anything which is more than 3 milligrams becomes clinically apparent. Before 3 and above 1, it is called laboratory jaundice. When it is more than 3, it is called clinical jaundice. So, the clinical presentation of jaundice, that is peripheral yellowing of sclera, is called scleral icterus, and it will develop when serum bilirubin increases more than 3 milligram per deciliter. As the levels increase, the skin progressively discolors from lemon yellow to apple green, especially if it is long standing. The green color is due to biliverdin. So, even if somebody's color appears greenish, it is also known as jaundice. Although the pigment responsible for the green color is not bilirubin, is biliverdin. When we look at a patient who is a patient of jaundice, there can be only few differential diagnoses that can come to your mind if jaundice is not there. One of them is keratinoderma, which is seen in healthy individuals who eat a lot of vegetables and fruits that contain carotene, like carrot. So, technically, it should spare the sclera. It classically does not involve the sclera. So, you will see it on the palms, you'll see it in the skin, but then you will not see on the sclera, not on the eyes. That is one of the biggest difference between hypercarotenoderma and jaundice. Second is a drug known as quinacrine. Now, this quinacrine, it is an antimalarial drug which is used to treat giardiasis and some types of SLE, which leads to yellowish discoloration of the skin in up to one third of the patients treated with it. So, if you are having any doubts that your patient could be having a drug related or a diet related discoloration of the body, then only two differential diagnoses should come to the mind. One is hypercarotenemia, which is also known as caroteninemia, and the second is quinacrine toxicity or quinacrine effect. Bilirubin, when we see it in the lab report, it has actually two components. One is unconjugated and the other is conjugated. Now, unconjugated is a fresh bilirubin which has been just created as a byproduct from the degeneration of hemoglobin. And once it reaches the liver takes it through some chemical processes and then becomes the conjugated bilirubin, which is combined and denatured to become water soluble. Either of them can rise, leading to jaundice. So, as a detective, whenever somebody tells you that the bilirubin level is 6, you must ask which fraction is elevated. Is it the unconjugated or the conjugated? So, conjugated hyperbilirubinemia. Let us first see this. So, hemoglobin is denatured into bilirubin, and this bilirubin goes to the liver as unconjugated bilirubin, and once it is in the liver, it is known as conjugated bilirubin. So, if somebody has conjugated hyperbilirubinemia, that means the liver is unable to throw it out into the excretory system. It could be a defect in the anion transport or canalicular organic anion transport, as it is known as, which is called Dubin-Johnson syndrome, or it could be a problem with the reuptake of conjugated bilirubin, as seen in Rotor syndrome. So, Rotor syndrome, you can imagine, like whenever the conjugated bilirubin is excreted into the CBD, it goes into the intestine. At these points, what happens is through this pathway, there is a motor which recycles this bilirubin. That motor is defective in rotor. So you can remember it by this mnemonic that in rotor the motor is defective. What does the motor do? Motor causes reuptake of the conjugated bilirubin. So when it is defective, the patient will have some amount of extra bilirubin absorbed, which leads to jaundice. Then it could be simply decreased intrahepatic excretion of bilirubin, which can occur in hepatocellular diseases like viral hepatitis, alcoholic hepatitis, cirrhosis, NASH, other viral hepatitis like Epstein-Barr virus, CMV, hepatitis C, other diseases like Wilson, autoimmune hepatitis. Now, these diseases, what do they lead to is that they synthesize bilirubin, but the liver cells they find it inefficient to throw it into the canalicular system. So the bile becomes overloaded inside the cell until it ruptures and this bile is absorbed into the blood circulation, leading to hyperbilirubinemia. Then on the other spectrum is cholestatic liver jaundice, whereby there is an obstruction at the level of the canal into which the bilirubin was to be thrown as a byproduct. So if there is an obstruction in the canal, that means the hepatic bilirubin will not be thrown into the intestinal system. So that means it is an obstructive jaundice or cholestatic liver jaundice. This is called stasis of the bile, cholestasis. So seen in biliary cholangitis, sclerosing cholangitis, and other infiltrative diseases like amyloidosis, lymphoma, sarcoidosis, tuberculosis, they can form granuloma obstructing the pathways or the canaliculi so that the bile is being sent into the canalicular system, but the canalicular system is blocked somewhere. Hence, the water or the bilirubin it seeps out into the system. It is just like a society. People living in the society are living in their homes and they are flushing their potty, urine, everything into the flush. So it is toileted into the sewerage system and then taken from there to the outside to the main public sewerage system. So exactly the thing is happening here that jaundice is thrown into the flush, goes into the private sewerage system of the home, and then it is thrown into the public sewerage system. So wherever there is a blockage, the smell will be there in the house. So this smell in, is jaundice in the case of bilirubin. Sepsis and
Sir,
other high.
can you
Yes.
repeat this Rotor syndrome and motor syndrome problem, sir? Can you repeat?
Yeah, basically what happens is when the bilirubin is synthesized and thrown into the canaliculi, not all of it is excreted into the system, it is reabsorbed. So whenever there is a defect at the level of the sinusoidal reuptake of conjugated bilirubin, that bilirubin remains in the hepatic sinusoids and it is reabsorbed and leading to jaundice. So the motor is defective. Okay.
Hmm. Hmm, hmm. So this is the conjugated bilirubin.
Yeah, this is conjugated. Then other things that lead to jaundice is total parenteral nutrition, drugs and toxins like contraceptives, rifampicin, probenecid, steroids, chlorpromazine, herbal medications like kava, Jamaican bush tea, arsenic, very important positive agent for hepatic crisis in sickle cell disease. Now, this also leads to conjugated hyperbilirubinemia and of course, pregnancy is a known cause of cholestasis. Now, coming to extrahepatic cholestasis, that means obstruction is at the level of the ducts which are outside the liver, like colodocholithiasis, that is a stone in the CBD, or any tumor, cholangiocarcinoma at the level of the ampullary duct or head of the pancreas, which is like this. So, if the head of the pancreas compresses, there will be bilirubin increased, and pressure in the CBD is risen, and hence leading to jaundice. Then other conditions which are rare, like extrahepatic biliary atresia, that means the extrahepatic biliary ducts are not even acute and chronic pancreatitis strictures. Last time I told you IgG4. Those strictures can form. Chronic parasitic infections can also lead to stricture formation like ascariasis, lumbricoides, liver flukes, strongyloides. All of them can lead to jaundice. Now, this is a easier jaundice to detect. Why? The levels are high. Conjugated bilirubin is water soluble, hence it imparts a lot of yellow color to whole of the body. So this is easily seen. Now the problem is with unconjugated hyperbilirubinemia, which is excess production of bilirubin, which causes a very slight jaundice. Slight. You can see that it is less than 5 or 6 usually. So most common reason for excess production of bilirubin will be hemolytic jaundice, extravasation of blood in the tissues, and reabsorption of that hematoma and its degradation as bilirubin. This erythropoiesis leading to defective RBCs. Defective RBCs are picked up by the spleen and damaged, and hence more bilirubin is formed. Or there is a reduced hepatic uptake of bilirubin as seen in Gilbert syndrome. Gilbert syndrome is the most common cause of benign jaundice. Patients will have jaundice, but then they will only be a laboratory jaundice. Rarely it is clinical jaundice, it is less than 3. The problem is that the, the regular bilirubin that is being produced is produced in a normal level, but its uptake by the liver, the hepatic cells, is decreased because of the problem with the uptake receptors that is seen in Gilbert syndrome. Okay, then if unconjugated bilirubin has to undergo an enzymatic process to become conjugated bilirubin, that means if that enzymatic process is defective, then that unconjugated bilirubin will never be converted into conjugated bilirubin. So this enzyme, these are called the glucuronidases. Now these glucuronidases, they are absent either entirely, like in Crigler-Najjar syndrome type 1 and 2, leading to a very dirty type of uh, unconjugated hyperbilirubinemia and kernicterus present right from the birth. Hyperthyroid and estrogen states can also produce the same unconjugated hyperbilirubinemia. The differential list is small but is very significant. Now, what is the pathophysiology of the jaundice? We can easily understand it by dividing into 3 phases of bilirubin metabolism, that is prehepatic, hepatic, and post-hepatic. Prehepatic is that the bilirubin. Just a second, let me pick it up. Hello, hello, जी हाँ जी हाँ जी कोई गल नहीं बेटा मैं देख रहा. So prehepatic, as we understand that bilirubin is the end product of heme. So it in the reticuloendothelial cells of spleen, liver, bone marrow, the heme released from RBCs, it undergoes series of reactions to form bilirubin. This is the final reaction. As far as hepatic uptake is concerned, so hepatocellular uptake, the bilirubin released by the reticuloendothelial cells is seen in an unconjugated form. It is transported to the hepatocytes bound to the albumin. So the unconjugated bilirubin is albumin bound, which causes its solubility in the blood. At the level of liver, this bond is broken and the bilirubin alone is taken up into hepatocytes through a carrier membrane transport and bound to proteins in the cytosol to decrease the efflux of bilirubin back into the plasma. Now you have to understand that a very important condition called cirrhosis of liver, it can lead to jaundice. How does it lead to jaundice is in part that albumin production is decreased. Albumin production, when it is decreased, it will not bind to the unconjugated bilirubin. Hence, the unconjugated hyperbilirubinemia can occur in case of jaundice, can occur in case of cirrhosis because there is less albumin available to bind to the unconjugated bilirubin. Then, after conjugation, or the unconjugated bilirubin proceeds to the endoplasmic reticulum where the enzymes UDP glucuronide transferase are present. They lead to conjugation of the bilirubin to form conjugated